Step 4. Radiologic signs to specifically hunt for direct signs on a tooth. Thin longitudinal hypodense line in the dentin or the root cementum. Fragment, separation or step, particularly in multi-rooted teeth, the palatal root of the maxillary molars or the mesial root of the mandibular molars. Indirect signs, bone or the PDL, J-shaped, C-shaped lesions wrapping around the root, mid-root vertical or angular defect with intact coronal bone, loss of buccal or lingual cortical plates adjacent to one root surface, halo radiolucency encircling the root or the furcation area, especially post and core seen in the premolars or molars. Remember, bone pattern may be present even when the actual fracture line is not visible on CBCT, and CBCT can still add value in such cases. 5. Common pitfalls and how to avoid them. Number 1, metallic artifacts, post, crowns, gataparcha can create linear streaks that mimics the fractures or masks the fractures. Read the slices immediately above and below. True fractures stay in alignment with the root. Artifacts often change position and orientation. Partial volume effect or thick slices. Large voxels which are greater than 0.3 mm may average out a narrow fracture, which is false negative. Use high resolution protocol where vertical root fracture is the question. Normal anatomy mistaken for fracture. Palatal grooves, developmental defects, large accessory canals. Check the continuity of the enamel or cementum surfaces and compare across different planes. MAR overuse. Some MAR filters reduce both noise and true fracture contrast, thereby lowering the sensitivity. If the scan was acquired with MAR, examine raw data if accessible. Ignoring the clinical context. CBCT alone should not be the sole determinant. Integrate with the history of endo, post, core, probing pattern, bite test, transillumination, staining or surgical findings. So what should be your quick chairside checklist for vertical root fracture on the CBCT? When you open a CBCT for suspected vertical root fracture, run through, confirm high resolution small field of view, approximate voxel size, axial plane fracture line, double PDL, mid-root crestal or cortical changes, coronal or sagittal, continuity of the line, J-shaped, halo, angular defect, cortical plate loss, correlation. Does the CBCT finding match the deep narrow pocket, sinus tract or pain on biting? Artifacts, metal streaks, motion, distinguish artifact versus the real fracture. Grade your confidence. I am definite, most probable, equivocal, unlikely, and document that in the report. Hope this helps.